We will speak today in this lecture about the approach using high resolution CT for focal lung disease, solitary pulmonary nodule or nodules, as well as masses. First, I would like to thank Professor Dr. Omnia Jamaluddin for her major help in this presentation. What is our aim in reading the high resolution CT of the chest for a focal lesion? To tell, is it benign, is it malignant, or it is potentially malignant lesion? This is crucial for it. By definition, nodule is a well circumscribed round or oval lung opacity less than 3 cm in diameter, which is completely or most of it is surrounded by parenchyma. While opacities larger than 3 centimeters in diameter are called pulmonary masses and are differentiated from solitary pulmonary nodules because they have higher likelihood of being malignant. It is important to distinguish those opacities that reflect solitary pulmonary nodules, which should be spherical in shape, from densities that are actually flat or pancake-like. Using the two-dimensional views, that's to say in the coronal and axial or sagittal and axial and so on. For this example, what is this? It seems for me this is a nodule rounded in shape. We can tell a lot about it. It simulates deposits, but should be sure that this lesion is spherical in two perpendicular views, because here it is just a flattened nodule or fibrotic nodule. This is more or less benign. This is a fibrotic nodule not representing a suspicious lesion. So before you tell that this is a suspicious nodule, you should be sure whether it is rounded or spherical or just flattened like this. This is the importance of using MPR. Okay. Those solitary pulmonary nodules that don't meet the specific benign criteria should be considered indeterminate and almost always will require further evaluation or at least follow-up. In the coming few minutes, we will go through the criteria that we use to analyze a focal lung lesion, starting like pathology, starting from size, shape, associated lesions, other signs, certain densities, growth rate, contrast enhancement, and so on. And each one we will try to put for these signs to see the diagnosis. Regarding size, lesions greater than 3 centimeters in diameter have a greater than 90% possibility of malignancy. Conversely, small lesion size alone is not a reliable predictor of benignity, particularly if the lesion is detected CT. This had led to the recommendation that nodules 4 mm in diameter in low-risk patients require no follow-up. We will see this. This table tells us about the relation between the size and the probability of being malignant. More than 3 centimeters, you can think like this, 97%. Less than 1 centimeter, 35%. For example, this is a very tiny lesion, as you see, small adenocarcinoma detected. It was measuring about 4 mm, and on follow-up, it has increased in size. So the rule here also cannot be that solid. You can detect a lesion in its very early stage at millimeter size, and follow-up here can show its growth. Because of the high resolution criteria of CT now, we see a lot of micronodules that we used not to see in the old days of the single slice CT. This makes a problem for us. So, especially that we see these nodules in patients with known cancer breast or something like this. So, it is wise for small nodules, which is less than 8 millimeter, to follow this table. If the nodule is less than 4 millimeter, in low risk patients, it means that he's not a smoker, he doesn't have malignancy elsewhere, no need for follow-up. But if there is high risk patient, follow up at 12 months. From 4 to 6 millimeter, low risk patient is followed at 12 months, high risk patient followed at 6, 12, 18, and 24 months to say that these lesions are just benign granulomata or something like this. If the lesion from 6 to 8 millimeter, follow up in low risk patient at 6 to 12, 18, and 24 months. And those at high risk, you should start follow up at 3, 6, 9, 12, and so on. Regarding the shape and margin, smooth nodules are benign, whereas lesions with spiculated margins, which is called corona radiata, are much more likely to be malignant. Lung carcinomas tend to be irregular in shape, as I have said, lobulated, notched, concave margins, but granulomas are often rounded. Hamartomas and metastases may be rounded, oval, lobulated. Scar of areas of atelectasis or scarring may appear linear or angular. Arteriovenous malformation or mucus plugs may have their own characteristic shape. AVM may appear serpiginous. Mucus plugs within bronchi may give the appearance of finger and glove appearance. A lobulated margin can indicate either benign or malignant etiology and is most often seen in hamartomas, peripheral carcinoid tumors, and adenocarcinoma. So as you see, there is 100% feature that can tell you that this lesion is benign or malignant. But the idea is that you collect or you gather all the signs together. For example, you have a rounded lesion, it is rounded in shape, it contains fatty density inside, there is no speculation, there is no lymph nodes, the patient is not complaining, so it is more or less toward benignity. For example, hamartoma. And the other, you have a lesion having have no speculated border, but its size is larger than 3 centimeters. There is puppy appearance inside. The patient has lymphadenopathy, have metastasis elsewhere. You can think this is adenocarcinoma. This is the idea. You collect, you give your diagnosis by analyzing all the signs of the lesion, as we will later on. This is a solitary pulmonary nodule, very well defined. It seems to have calcification inside. Usually this is a granuloma. This is what is meant by speculation. The border is irregular, having corona radiata coming from it. This speculated appearance is typical for adenocarcinoma. Again, speculated appearance of adenocarcinoma and pleural tags or pleural lines, as we will see later on. But put in mind the following. Look for this lesion. It is very well defined, smooth as you see, but on follow-up, it becomes larger in size, lobulated in outline, and this was a case of adenocarcinoma confirmed by, it was a solitary metastasis confirmed by biopsy. On the other hand, speculated border, look for this, a lesion with a speculated border, but on follow-up, it disappeared. This was a case of resolving pneumonia, or something like this, and it was very benign. Okay, resolving or organizing pneumonia. So, speculated border, when you see it, in most of cases, it is representative of a neoplastic process. But in some cases, if the history is matching well, it can be seen in resolving pneumonia, organizing pneumonia, and healing abscess. It creates surrounding desmoplastic reaction or fibrotic. As we have discussed, the edge or the margin, sharply marginated, can be seen in granuloma, hamartoma, benign tumor, carcinoid tumor, and metastasis. While speculated or irregular or pleural tail signs are seen in bronchoalveolar carcinoma, cancers, granuloma, or focal scarring. This is the differential diagnosis of each type of the edge margin. Presence of satellite lesions. Look for this. This is a lesion, okay, and surrounded by other tiny satellites. Presence of a larger central nodule usually indicates a granulomatous process, most often seen in TB and histoplasmosis. What is meant? A large lesion surrounded by tiny satellites. This is called satellite. Pleural tail. What is meant by pleural tail? One of the lines go from the region to touch the pleural surface. Okay, you can see it in CT more easily than seen in X-ray. It is a linear opacity extending from the lung nodule toward the pleural surface. It can be seen in either benign or malignant lesions, but when associated with malignancy, it is seen most often in pulmonary adenocarcinoma. Coma tail sign. Coma tail sign is a bundle of curved linear bronchi and vessels extending into the hilar aspect of a peripheral nodule or mass that lies adjacent to the pleural thickening, and it is characteristic of a benign condition called round atelectasis. As you see, there is a lesion. From it, there is an extending curvilinear structure that represents the coma tail sign, and it is seen in round atelectasis, which is a benign condition that can be seen in elderly and also can be seen in patients suffering from asbestosis. Look for the lesion and what is meant by the coma tail. Bronchovascular structures going to the nodule, and as if they are swirling or like this, they are going to the nodule, and it is associated with a characteristic condition called round atelectasis. You remember halo sign? I have explained it in the previous lecture. It means that we have a nodule or a lesion surrounded by a rim of ground glass opacity. As I've told you, this can be seen in cases of invasive aspergillosis due to a perilesional hemorrhage, or in bronchoalveolar carcinoma due to either hemorrhage or infiltration by malignancy surrounding the lesion. This is what's called sign. And this list is the differential diagnosis of halo sign. It can be seen in fungi, bacteria, viruses, and so on, as well as metastatic tumor, Kaposi sarcoma, bronchoalveolar carcinoma, and adenocarcinoma. The reverse of halo sign, which is called atoll sign, also I have explained in the previous lecture. It means that we have a core of ground glass opacity surrounded by a rim of consolidation, whether it is complete or incomplete. And the first time this sign was described in organizing pneumonia or cryptogenic organizing pneumonia, but actually this reversed halo sign can be seen in many other diseases, including pulmonary infarction, bronchoalveolar carcinoma, pneumonia, and unfortunately, nowadays it is seen in cases of COVID-19. Let us now go to analyze the internal density of a focal lesion or solitary pulmonary nodule. We can speak about calcification, fat, cavitation, air bronchogram, papulolucences, mixed solid and ground glass nature. First of all, calcification. We have benign pattern of calcification and malignant pattern of calcification. What are the benign pattern of calcification? It could be central, it could be lamellated or laminated, popcorn-like, or diffuse calcification. All of these four patterns are benign patterns of. Why? If you see calcification eccentric within the lesion, or small flex-like or amorphous calcification, these are signs of non-benign pattern or malignant pattern of calcification. Let us see. This is diffuse calcification of a granuloma. Okay, curvilinear calcification or concentric that is seen in histoplasma granuloma. Central or what is called bullseye calcification, then central calcification. It is seen also in hamartoma or in histoplasma. This is multiple confluent nodular foci of calcification representing popcorn calcification. This is typical for hamartoma. Central calcification in granuloma. Okay, and this is also again popcorn pattern of calcification. But rarely metastasis in patients with osteogenic sarcoma or chondrosarcoma may show calcification or ossification in the bone-forming or cartilage-containing portions. Calcified lesions thought to be benign should be followed at least for 2 years to tell that they are benign. So we mentioned that this is, for example, a granuloma. However, follow-up is recommended to monitor its behavior. Let's go to the other two malignant types, eccentric and small flex-like. This is a lesion lobulated in margin with corona radiata, and the calcification is eccentric. And this is an example of the amorphous or flex-like calcification in malignant lesion. Okay. Sometimes calcification occurs in this as a dystrophic calcification in lung cancer. This is a typical lesion showing corona radiata and pleural tails with irregular margins and shows amorphous-like pattern of calcification. This is the pattern of calcification. Let's go to fat. Fat within a solitary pulmonary nodule with a small or lobulated margin is diagnostic of pulmonary hamartoma. About 60% of hamartomas have fat, with a minority also shows coarse calcification like popcorn and so on. Rarely, metastases from renal cell carcinoma or liposarcoma may contain fat. This is particularly important. Why? Because in BET FDG PAT activity has been described in pulmonary hamartomas because the presence of fat. And a positive PET scan in such setting might prompt unnecessary biopsy or resection. That's to say, hamartomas may show some activity in PET-CT due to the presence of this fat. So you should analyze the initial image. Presence of fat, calcification, well definition of the lesion is more or less with hamartomas, malignant lesions. The differential diagnosis of fat inside lesion, of course, hamartoma, lipoma, liposarcoma, lipoid pneumonia, histoplasmoma. Let us see if this is a lesion, huge lesion containing fat. This was a liposarcoma. And this is a typical hamartoma, contains calcification and spots of fat as you see. This assure you that this. Regarding low attenuation or low density within the lesion representing fluid. As you know, fat density is minus 50 to minus 100, while fluid is from minus 20, 30, 0, 20, 30, and so on. If you find low attenuation inside the lesion, it could represent benign cystic lesions such as bronchogenic cyst containing fluid, congenital cystic adenomatoid malformation, fluid-filled cell or bulla or infected bulla. And as you see, the attenuation is usually from 0 to 20 or 30 and very thin with very thin or invisible walls. Also, low attenuation can be seen in myocardial impaction in cases of allergic pulmonary aspergillosis, but sometimes hemorrhage occurs on top and calcification also may develop, so the attenuation will increase and will not remain low attenuation. Lastly, a necrotic tumor or a fibrotic mass or lung abscess or infarction may have low attenuation center on CT, but these lesions have thick and perceptible. This is example of hydatid cyst. It contains fluid as you see, and sometimes there is collapse of the layers, internal layers, giving this appearance or lily, water lily appearance characteristic of hydatid cyst. This is an example of lung fluid contents. Regarding cavitation, cavitation may occur in necrotic malignant solitary pulmonary nodules, but doesn't allow the distinction between benign lesions as inflammatory lesions such as abscess, granulomatous lesion, and Wegener granulomatosis, pulmonary infarcts also can cavitate. Cavitation within a malignant solitary pulmonary nodule is most typical of squamous cell carcinoma. Once you see a lesion, that a malignant lesion in the lung that cavitate, it is usually squamous cell carcinoma. It has this reputation. They have, the authors tried to take some measures to differentiate benign abscess from malignant abscess. What is meant by malignant abscess? Cavity containing air fluid level with in a patient compared to another patient having an abscess. The idea, they tried to use the wall thickness. They said that wall thickness less than 5 millimeter is often benign, whereas the majority of those with a wall thickness greater than 15 millimeters are malignant. They said that if the wall thickness is irregular and more than 15 millimeter, it is suspicious to be malignant. However, cavity wall thickness is not a reliable criteria to differentiate benign from malignant, and you should be cautious. And of course, history is very important to differentiate benign or inflammatory abscess from a cavitating neoplastic lesion or abscess. This is an example of cavitation inside a solitary pulmonary nodule. As you see, it has corona radiata or spiculated margin, and in addition, there is a core of cavitation. Okay, and this is an example of a cavitary lesion. It starts as solid, start cavitation, the cavity increases, and even it can show air fluid level simulating abscess, and more or less you see that the wall is thick and it is irregular. Usually lung abscess, the wall is thin, especially in chronic abscess, the wall is thin and it is more or less smooth and having not this appearance of bossy shape or irregular shape. There is something called air bronchograms or air bronchulograms that is equal to the what is called bubbly lucences within the lesion. Air bronchogram or cystic or bubbly lucences within a solitary pulmonary nodule is highly suggestive of pulmonary carcinoma. Although lymphoma and occasionally some benign lesions such as organizing pneumonia or mass-like sarcoidosis can have air bronchogram. Papulocences are common in adenocarcinoma with bronchoalveolar cell features, okay, low-grade. This is what is meant. You can see papulocency inside the lesion. In addition, it has corona radiata and pleural turn. This is a case of carcinoma. This table shows the differential diagnosis of air bronchograms, adenocarcinoma, bronchoalveolar carcinoma, silicosis, sarcoidosis, concomitant masses, focal pneumonia, infarction, round atelectasis, bronchiolitis obliterans, organizing pneumonia, lymphoma, and so on. Air crescent sign. In some patients with cavitary nodules or lung cyst, a mass or nodule may present within the cavity. Air outlining or capping the superior border of this mass result in a crescent-shaped collection of air termed air crescent. This is what is air crescent. It is a cavity containing a structure and air. This air forms what is called crescent sign. This sign is more than 80% representative of what we diagnose as mycetoma. Mycetoma is a phenomenon in which fungal growth occur inside a chronic lung cavity. Okay? To be sure that this is an air crescent sign, you sometimes may need to repeat the examination in prone position. The ball or mycetoma will drop by gravity and the crescent will still in the superior border. Okay, this is important. Why? Because sometimes some cavities may contain carcinoma. Carcinoma can grow inside a cavity, but it will be fixed to one wall, while mycetoma is movable. It can, by gravitational or position, change its position. So, air crescent sign, to be sure that it is a mycetoma, you should do a changing position or prone from supine to maintain that the air is free all around the region and the content is movable. The most likely cause of air crescent sign is, of course, mycetoma, but the differential diagnosis may include other entities, as you see in carcinoma inside a cyst, cavitary carcinoma, clot in a blood cyst or a cavity, mucus plug, papillomatosis, and so on. But common things are common. If you see crescent sign, the first thing to think is sometimes this is a rare case. Pulmonary gangrene can give the same appearance, crescent sign and gangrenous portion that will not move mycetoma. Presence of air fluid level. Usually it is diagnostic of lung abscess. As I have told you, sometimes we have the entity of malignant abscess that can be that can suffer from superadded infection, hemorrhage, and so on. But air fluid level in a lesion in the clinical status of fever, leukocytosis, and so on is suggestive of lung abscess. Any infected cyst or cavitary lesion may be associated with air fluid level, and air fluid level is uncommon in a cavitary carcinoma but may be seen in the presence of hemorrhage or superadded infection. This is how we can see air fluid level. Air, straight line, and fluid density here. Feeding vessel sign. The feeding vessel sign is present if there is a small pulmonary artery is seen leading directly to a nodule. This appearance is most common in metastasis, differential diagnosis, infarctions, this is repeated, septic emboli, and arteriovenous fistula, because of course it has a feeding artery. It is less common with primary lung carcinomas or other lesion benign granuloma. What is meant? You see a nodule that is supplied directly by an artery. Okay, these are metastases. Again, this is an infarction, triangular in shape, and this is the feeding artery, and as you see here, there is pulmonary. Again, these are septic emboli. Okay, the idea is that either the malignant cells or the infection or the infected ampullus go through the artery or arteriole until it blockades and make either metastasis or infarction or septic ampullus or septic infarction as in this. This is actually not of importance to make a diagnosis, but it has an importance for our colleagues who do bronchoscopy. Presence of positive bronchus sign. It means that you see a bronchus reaching to the lesion. This is very good to the physician because he knows that he can reach to the lesion through this patent bronchus to take biopsy or to see it. Okay, this is a helpful. This is called positive bronchus. Mixed solid or ground glass lesion. We have regarding the density of the lesion could be totally solid or subsolid. What is meant by subsolid? It can be either pure ground glass or partly solid, partly ground glass. So the lesions could be solid or subsolid. Subsolid means that it is partly solid, partly ground glass, or partly solid or totally or purely ground glass attenuation. Some people may use the term non-solid, so they can reclassify into solid, non-solid, which is ground glass, or partly solid, partly glass. Actually, there is a lot of debate or controversy here. Pure ground glass attenuation or non-solid solitary pulmonary nodule reflect one of three conditions: focal interstitial fibrosis, atypical adenomatous hyperplasia, or adenocarcinoma. The rate of malignancy within a mixed attenuation or partly solid solitary pulmonary nodule is high. So if you see a partly solid lesion, this is not benign. You should be cautious about this pattern of density. It is important to remember that the majority of malignant solitary pulmonary nodules are completely solid in nature, whereas the majority of solid solitary pulmonary nodules are benign and represent granulomas. This is somewhat confusing, but let us try to re-summarize. If you see a lesion in ground glass, focal lesion of ground glass density, or partly ground glass, this is more or less suspicious. If you see a lesion that is totally solid, it is 50% benign, 50% malignancy, and look for the other signs that can help you about calcification, about the margin, about the presence of lymphadenopathy, and so on. Okay, as you see, this lesion, we have part solid and part ground glass. Okay, and of course, papulolucences. This was a case of carcinoma. Most of patients who have a small pure ground glass attenuation nodules will require follow-up CT. This is very important. If you find increase in size, a change in the attenuation, or a change in the marginal characteristics in follow-up, this is very serious that the lesion is malignant and biopsy or remove it. This is an example. Partly solid nodule. Some part here is solid and most of the lesion is ground glass. On follow-up, the lesion turned to be almost solid and the margins are irregular. This was a case of adenoma. Put in mind that subsolid lesions are often negative in PET and PET-CT. due to low metabolic activity within these lesions. Subsolid lesions that exceed 10 millimeter in diameter are best to be biopsied or resected, particularly if we have a history of high-risk patients such as those who are smokers or having malignancy. Regarding the growth of the lesion, another controversy and somewhat misleading ideas. But let us simplify it and try to know. If you have a lesion that grow slowly, but not that slowly, within months, this is not a benign lesion. If you have a lesion that will grow rapidly, this is usually an inflammatory lesion. Let us read these sentences. The absence of growth of a solitary pulmonary nodule over at least 2 years period of follow-up, as determined from review of previous chest CT or radiographs, is a reliable indicator of benignity. So, stable within 2 years, very good. Given the prolonged calculated doubling time of some slow-growing adenocarcinoma, most radiologists who detect any growth in size of an solitary pulmonary nodule will recommend a definitive diagnostic procedure such as biopsy. So you may have very slow growth, which is criteria of a slow-growing adenocarcinoma. If you find this, still there is suspicious. Nodules that double in volume in less than 30 days are typically infectious or inflammatory, but in minority there are some aggressive lymphomas or rapidly growing metastases that can double its size in 30 days. Nodules that double in volume in greater than 400 days are usually benign neoplasm or sequelae of previous pulmonary infection. In general, the lack of growth over 2 years period is reliable in determining the benignity of a nodule. This criterion doesn't apply to subsolid nodules because some well-differentiated adenocarcinomas and bronchoalveolar carcinomas can double, having doubling time in more than 1,000 days. You know there are some now software in our workstation that can measure the volume of a nodule, and you can use it to measure the volume, the shape and appearance, and you can make comparison between the old studies and recent studies. It analyzes the nodule and tell you what about its total volume, what about its doubling time, its shape, its density changes, and this is used in abroad, especially not here up to my knowledge, for follow-up or screening of patients for malignancy, especially those who are. This is an example, very tiny nodule with doubling time. As you see, it has increased in size after 6 months, and this was proven to be adenoma. Another, as you see, patient with a lesion like this, and on follow-up, it has increased in size, become more speculated border. This also potentially malignant lesion. Of course, if you follow up a lesion and it decreases in size, this is very benign lesion. Usually it is an inflammatory also something. Again, metastasis, small, and on follow-up, as you see, the doubling time was less than 30 days. This is a very aggressive tumor that doubles very rapidly. Of course, this patient doesn't have fever, doesn't have features of inflammation, and no other primary. Regarding contrast enhancement, we have two patterns: contrast enhancement and contrast opacification. What is meant by contrast opacification? It enhances markedly like vessels. I will show to you in few seconds. Actually, we don't do this. To do contrast enhancement or to assess contrast enhancement within a lesion, you should do pre-contrast and then post-contrast. But actually, what we do in our daily practice, we go for post-contrast CT of the chest immediately, and we don't do CT of the chest pre and post-contrast for fear of the exposure, radiation exposure. But if you want to measure contrast in a lesion, you should have a pre-contrast, you measure the attenuation, then you measure the attenuation after contrast administration. If you have an enhancement value more than 15 Hausen field units or less in a is virtually diagnostic of a benign lesion. Typically, malignant nodules enhance more than 20 Hausen field units, while benign, as I've told you, less than 15. Some people use these criteria. This technique should only be performed on nodules larger than 5 millimeter and relatively spherical in shape and homogeneous in attenuation. Take care that if there is cavitation, necrosis, or fat, the density, of course, will be less than 20 Hausen field units. So it is preferable for solid homogeneous nodules. Actually, we don't do this in our. But in mind also, some active granulomas may show marked enhancement at CT. This is a bit 4. Malignant lesions greater than 3 centimeters may show internal necrosis and fail to enhance, giving you a false negative study. Okay. This is an example of a lesion, pre-contrast and post-contrast, and as you see, there is some sort of this is pre-contrast, and one of them, I think this is post-contrast. There is enhancement here. The lesion shows enhancement, denoting that it is a malignant. As you see, there is pleural, tail, and beta. The other concept, which is easy for us to see, that the lesion is enhancing like nearby vessels, following the common pool of the pool, contrast pool within the nearby vessels, whether they are the aorta or veins or something. This means that this is a vascular lesion. Okay, we can see in pulmonary arteriovenous malformation, pulmonary varix, and pulmonary artery aneurysm. This is example of pulmonary artery aneurysm, arteriovenous malformation. Okay, let us now speak about what the benefits and the pitfalls of the now available technology of PET-CT. It is most useful for evaluation of probably benign solitary pulmonary nodule when biopsy cannot be performed. The degree of FDG accumulation is measured using standardized uptake value, which is called SUV. SUV of lung cancers usually is more than 2.5. FDG PET have sensitivity of about 95% in detecting malignant solitary pulmonary nodules 1 centimeter or more in diameter, with a specificity of 80%. Take care that the specificity is not high. This is an example lesion with a speculated outline, and it has taken the tracer, and its SUV is very high. As you see, it is very bright. This is a malignant. But it is not a magic, and it may harm us if you think that this is the most accurate one for diagnosis, because we have false negative and false positive results of PET-CT regarding solitary pulmonary nodule. Some of the well-differentiated adenocarcinomas may be negative in PET-CT. Peripheral carcinoid tumors or carcinoid tumors are negative in 25%. Lesions smaller than 1 centimeter may show no activity in PET-CT or PET. This is an example. False negative pulmonary PET-CT with a metastasis from Ewing sarcoma, rounded lesion, and is not active. Another example, carcinoid, central carcinoid, it is not active. Regarding false positive studies, Some granulomas with active inflammation may appear very hot in PET-CT. Focal areas of organizing or resolving pneumonias also may appear like this. Sometimes hamartomas, as I have told you, because the presence of fat may result in high activity. In these cases, resection or biopsy may be needed for diagnosis. This is an example. This is a nodule due to TB, and it was very active, as you see here. Very bright and taking the, okay. What should we do? We find a lesion. We will go step by step analyzing the lesion regarding its size, shape, pleural tail, and other signs. Okay? And we put all these signs together, whether they are favoring benignity or favoring malignancy or indeterminate. If you are damn sure that it is benign, okay, we will write this is a nodule fulfilling the criteria of benignity, including 1, 2, 3, and so on. Most probably this is a granuloma or hamartoma. But you should write, please, for follow-up. If the lesion is definitely malignant, of course, you are right. This is a lesion fulfilling malignant criteria suggestive of neoplastic process for histopathological correlation. If the lesion is indeterminate, you can suggest close follow-up or to do other investigations, including PET-CT or biopsy and so on, and not to make the clinician calm about this lesion. You should tell him that I'm not sure whether it is benign or malignant, and you should do something rather than radiology to confirm this. Okay? As I've told you, take the lesion, try to analyze it using all these items, and you can put 1 plus 2 plus 3 plus regarding benignity and malignancy, and you can make a sum of these findings, and you can by these signs suggest whether it is benign or malignant. Thank you much, and I hope that you got some information about how we can analyze the CT findings of a solitary pulmonary nodule or focal mass in the lungs. Thank you very much.